All right. So those of you who are following along, we're going to go over chapter 7, care of the patients with pain. All right. And if you see me looking at the computer, I am scrolling through the PowerPoint. I also have some key pages to highlight in your book. I'll be giving you those as we review it. So what's going on with patients with pain, right? They are assuming a very uncomfortable state of being. They're experiencing pain through what they call a gate control theory. This is where stimuli comes from the site of injury right to the brain, okay? And then pain is felt. There's different types of pain. How can we truly understand what pain is as it relates to a patient? That's where it becomes subjective information. I think you guys are all comfortable with understanding that the fifth vital sign, which is pain, is subjective. And there is a certain method to figure out or to characterize, assess that patient's pain level and what it means to them, how culture will have an effect on how they feel pain, how they will discuss pain, and how their care will be utilized or planned around their pain. All right, so here we're going to talk about the gate control theory, okay, and how it relates to your nursing care. We're going to talk about some types of pain, okay? So in this, we're going to talk about nociceptive pain and neuropathic pain. We'll talk about how it affects personal situations and cultural backgrounds, like I was saying. We're going to analyze the major difference between acute and chronic pain and what management looks like as far as what is your role regarding pain management for these patients. All right. The nursing process will also come into play with pain, just as it does with any other disease process, and how you, the licensed provider, is going to care for this patient. Okay. We've talked about before non-pharmacologic approaches to pain, how those are paramount to care for your patient. We just don't automatically go for chemical pain control. Sometimes it's not indicated, you know. There's different types of pain, somatic pain. We have stimuli that increases our pain perception, if you will. All right. So we're going to talk about the gate control theory. And again, I'm starting on page 128, which is chapter 7. One of the important vocabulary terms to highlight and include in your study plan for your next exam is the gate control theory. This is the theory that recognizes that other stimuli other than pain pass through the same gate. In other words, there is something competing at that gate. Think of horses coming out of the track. The gate is open and they're all running forward. When those horses are coming around the bend, think of the bend as different synapses or areas that pain can be assumed at. So if they're going around a curve, 5 horses at the same time, they're all going to get through the next gate that's coming up, essentially. Okay, if you want to think about it in that sense. Some pain impulses at this point can be blocked. Like if you want to utilize my horse theory, other horses will block the others from getting to the finish line. Okay. And then we can relate that to referred pain, but I will get into that in just a second. We talked last week about the urinary system, right? I feel like Professor Finken and I really beat that into you guys because we turned the sim into a complete lecture, but for good reason. Chapter 34's PowerPoints was almost 77 slides in length. It's huge. So we decided to make it a little bit different for you guys instead of sitting through 77 slides. Okay. So if you guys got a patient, let's say with renal calculi, right? And we're talking about pain right now. We're talking about nursing applications of the gate control theory. What do you think your priority should be as far as a pain assessment? right? With this patient with some renal calculi. They're having a kidney stone. Those of you who may have seen family members pass kidney stones or heard about it, or if you read through the chapter on it, you'll see that they elicited that you need to assess the location and the severity of the patient's pain. That's going to be important to understand. You had a question, Omar?
No. I just said pain management, analgesics.
Yes, analgesics. But before we even get to the analgesics, we got to do that assessment. That way we can manage the pain, because in the pain assessment, we're going to assess the severity of the pain, the character. We're going to follow through on the entire pain assessment. But yes, analgesics would certainly be indicated for this one. Okay, it's continuing on here. So remember I was talking about the horses coming out of the gate. You have, let's say you have 15 horses out of that gate at the same time. You ever seen a horse race where the gate lifts and all the horses and jockeys, it's like, boom, all out of the gate at the same time. Let's think of the horses as pieces of pain, okay? Competing to get to the same gate as it relates to the gate control theory. Those horses are all coming up at the same time. The greater amount of horses that are close to the gate, the more the pain will intensify. Okay, the greater number of horses that get to that gate, the more the pain will intensify. I say that over again because that's going to be important to know. That's going to help you choose, one, how you're going to assess this patient's pain, right? You're going to ask them what goes with it. PQRST is one way you can remember how to assess the pain on a patient. You can remember it via old CARTS. That's an acronym to look that up. I personally don't use that. I go by PQRST. However, you need to remember the questions to ask for pain. So for example, if I go into a patient's room and I'm assessing their pain, I'm going to swipe in, right? And then I'm going to say, are you having any pain today? And if their answer is yes, where is the pain? Right? Maybe they say it's in their abdomen. What's the character of this pain? Is it severe? Is it a dull? Is it an ache? Is it a stabbing? Maybe they say it's a stabbing pain. Well, then we want to assess time, right? When did the pain start? Oh, about 2 hours ago. Okay. What makes the pain worse? Relieving factors. Then you want to ask the precipitating factors. Oh, the pain gets worse when I eat, but it feels better when I lay down. Okay. What relieves it and what potentiates it, or what makes the pain increase? Okay. And then you need to assess if the pain refers anywhere. Is the pain traveling? Do you feel the pain elsewhere? Normally, if you ask the patient, do you feel the pain anywhere else, or does this pain travel to anywhere? And they're going to say, oh, yes, my abdominal pain, my epigastric pain, they're pointing right in the middle of their stomach here. It kind of radiates around to my back or my lower back, wherever they tell you. That becomes essential, okay? Because then we need to know how we can block this pain, like Omar is saying, analgesics, but certain medicines won't work on certain items. Meaning, if we've got pain from a bladder spasm, okay, we're not going to medicate them with Dilaudid. Maybe what's indicated better is maybe a BNO or BNA suppository, okay, or an antispasmodic, okay, because different pain works on different pathways and different pain receptors will receive the pain medication and distribute it appropriately to block the pain. Okay, let's continue on the PowerPoint here. So you have two different classifications of pain. You have nociceptive pain. This is associated with painful stimuli from somatic body tissue or visceral structures. This is just telling you that, hey, nociceptive pain is coming from either a tissue somewhere along the lines of the body or the integumentary system, or the pain is coming from your visceral organs, your abdominal region, right? Our organ system. Is it the stomach? Is it the pancreas? That's why it's important. This A&P really comes into play when understanding pain. That's kind of the best tip I can get for you guys as far as how you're going to use this lecture in your clinic, clinically when you go work. Okay, that's one of the best ways I can tell you how this lecture will be valuable to you when you go work at your job. Okay, which is really close in the future if you guys think about the bigger picture. All right, next, you got neuropathic pain. This comes from a dysfunction in the nervous system. Think about neuropathy, right? Your diabetics that have dysfunction of the nervous system, that involves an abnormality in processing sensations. Yeah, you're diabetics, right? What happens with diabetes? Your blood vessels become stenosed or hardened. We've got, with the hardening of the blood vessels, arteries and veins included, they're at higher risk for venous stasis ulcers, okay, which is going to be tissue impairment in the lower extremities to create an ulcer because the blood is now pooling. Okay, blood has sugar in it. Blood has an acidic level, as we understand it, the pH level. And when that sits, it creates problems. Other problems that can be associated with it is neuropathic or neurologic pain, like neuropathy. Okay. These are not related to tissue damage normally. This is related to another disease process that is giving the nervous system a dysfunction. All right. You have 4 phases of nociceptive pain. I do have a page number for you guys on that. It's 128 to 129. And you can see here on page 128, it goes into transduction, transmission, perception, and modulation. Okay. This will be important to know. Also, table 7.1 on page 129. That'll be also important to include on your study plan as well. Let me just go through my notes that I have here for you. Okay, so remember, visceral pain. Okay, I talked about organs. It also includes the lining of body cavities. Okay, visceral pain stems from organs and the linings of body cavities. Just to recap, neuropathic pain stems from peripheral and central nerve fibers, spinal cord, and central nervous system. Now you have another classification we're going to go into, and it's going to be somatic pain. This can be cutaneous or superficial, originating from the skin and subcutaneous tissues, or deep bone, muscle, and blood vessels, and also connective tissues. Okay, if you re-listen to this recording later, those definitions that I just gave you are going to be important to include in your study plan. All right. Transmission. Now we're on the 4 phases of nociceptive pain in chapter 7. Transmission involves movement of the pain sensation to the spinal cord. Another important definition to make sure that you notate. Okay. Now let's go into transduction. Begins when tissue damage causes the release of substances that stimulate the nociceptors and initiate the sensation of pain. Okay. Perception occurs when the impulses reach the brain and the brain now recognizes, hey, ouch, that hurts, right? Modulation occurs when the neurons in the brain send signals back down to the spinal cord by release of neurotransmitters. We were talking briefly, not last week, I think it was the week before, about dopamine, norepinephrine, epinephrine, and the neurotransmitters. And I did tell you guys to include that in your study plan, because neurotransmitters is like the vehicle, the mechanism of action, if you will, for the brain. This is the vehicle that goes through all the nerves drives along the nerve pathway to the brain. It says, honk, honk, here I am. I'm bringing you an impulse. What's the impulse today? Pain. That's what it's telling you. It's dropping off pain, right? It's like the Uber of the nervous system, dropping off pain or dropping off a sensation, if you will. Okay. Remember the afferent and efferent pathways and how they get to the brain. Okay. So so again, pain, subjective. Pain tolerance, this is where culture comes into play. Pain tolerance is the length of time or the intensity of pain a person will endure. How long can they take pain? How much pain can they take? Some cultures are more stoic than others. The Hispanic culture is famous for it. We will sit there in pain and barely shed a tear, and we'll be doubled over, and the nurse walks in. Are you having any pain? I can't tell you how many patients I've had, and family included, okay, because they're of that culture. We are of the Hispanic culture, and we're like, no, everything's fine, but yet you're in a fetal position. There's a lot of cultures that share that, not just Hispanics. But just know, read your patient, your nonverbal cues, okay? Clinically, this is important. You won't see nonverbal cues on your exam, but this is going to become huge when you guys are working, okay? Somebody with their feet pointed away from you, somebody literally holding their stomach doubled over in pain, but telling you, I'm fine, I'm fine. They're not fine. They're not fine. You need to take care of it because here's what happens. If we do not educate our patients on the pain that they're having, if they're a 10 out of 10, and they're also guarding, right? They got their hands over their stomach, they're hunched over, right? Their face is red, their vital signs are now totally increased, blood pressure's up, heart rate's up, they're breathing fast, tachypnic. You think they're in pain, right? Yeah, they're in pain. If they are at that level, it is harder to get them back down to a tolerable level. If they're at a 10, to even get them to a 7 is going to be an act of Congress, okay? We need to catch the pain early, whether you're going to do it pharmacologically or non-pharmacologically. Pain needs to be addressed because once it intensifies and reaches that 10 level, we're going to have problems. It's harder to medicate them. It's harder to bring them back down. Okay, then you're going to have respiratory depression because now they've received 1 milligram of morphine, followed by, hopefully not, but another milligram of morphine for breakthrough pain because they're still having pain. And now their respirations are 6. Problem. Okay, so we need to catch it before it gets out of hand. Psychological responses to pain: groaning, grimacing, right? Frowning, your, again, nonverbal cues, right? Tension, sweating, pallor, right? Or flushing. If their face is red, like I was just talking about, all those vital sign changes. What's going on in your patient? That's going to indicate pain. Okay. There we go. Cultural considerations. This is huge when it comes to pain management. Let me see if I have something in my notes about that. Hang on. Okay. So cultural, again, non-judgmental. We are non-judgmental as nurses. We don't care if you are the CEO of a major company, and we don't care if you're homeless. We are still going to treat you the same and take care of your pain, just the same way. Okay. I disagree with some of the major hospital systems that put a VIP on some patients. Say, oh, they're a VIP. Okay, but they're still having pain the same as somebody else is going to have pain. So again, non-judgmental, care for your patients. And if you don't know about a culture, I suggest you research it because that is your job. Learning never stops as a nurse. We always want to understand that we have a spirit of inquiry. Okay, even if it's for culture, do it. That way you can care for your patients properly. All right. And if they don't want any pain medicine, they have the right to refuse it. But maybe we can help in other ways. Get the family in there, see what they do. What's their cultural preferences? All right. Now, shifting gears, let's go into acute versus chronic. Acute is happening right now. Let's say if someone came in and they had a surgery, right? They had a surgery, an abdominal surgery, maybe a bowel resection. Let's use that. Okay. Are they going to have acute or chronic pain? They've never had a bowel resection before. Surgical procedure, yeah, that's acute pain. It's happening right now. Recent, just going on. Or from another injury that caused that tissue trauma. Okay. Could be hours to days. Now, chronic pain, this is months to years. Typically 90 days, 3 months is when you're going to be considered anything chronic. Okay, especially pain. If you got pain lasting for months to years, that's chronic. Okay, may have a known cause, right? Maybe from a syndrome or other disease processes. Okay, but it's important to understand the difference between those. Okay. Let's talk about chronic pain. In chronic pain, the spontaneous relief of pain is unusual. Okay. So what I'm saying is normally an acute pain medication, normally there is some relief. Okay, but it is highly suspect or highly unusual that spontaneous relief. Okay, so that if you were to see a question about chronic pain and some characteristics of it, spontaneous relief really doesn't happen. Okay, someone with fibromyalgia is not going to wake up tomorrow and say, I'm pain-free. We hope for that, but it's not associated with chronic pain, okay, or the disease process. Let's see what else we got on pain. Now, acute pain, this is going to resolve either to a therapy or to a medication. That's normally going to help it resolve, right? You have a migraine, you take some Excedrin, resolved. Acute pain, done, over with. Now, chronic pain, normally the prognosis is not that great because spontaneous relief is unusual, okay? So again, their pain relief is normally poor unless certain factors are removed. I didn't tell you guys before, neuropathic pain, such as neuropathy, like diabetic neuropathy. Excuse me, you're gonna have them, they get treated with, Neurontin is one of the most famous ones, gabapentin, right? But it's actually can be considered an antidepressant too. And it works on pain as well. So don't be surprised if your patient gets put on, if they have neuropathic pain, a tricyclic antidepressant. Okay, you want to include that in your study plan. That's going to be important. Okay, analgesics and opioids usually do not relieve neuropathic pain. The receptor sites don't work on that. It's not what's going on. Okay, their opioid receptor sites are not activated by that type of pain. So an opioid, remember from pharmacology, the lock and key enzyme theory, the lock and key, one has to fit into the other. Well, if the opioid receptor site isn't activated, opioid is not going to work on it primarily or at all. In reviewing pain, make sure you include in your study plan what terms describe quality of pain, okay? Throbbing is one of them. You may see terms like constant, mild, or intermittent. That's more of a time range versus a description or the quality of pain. Just want to notate that. Okay. Let's see here. Acute pain, again, may temporary, sorry, we got some background noise. I apologize. Hang on 1 second. Okay, so chronic pain, these can affect their quality of life. Okay, it's chronic pain. It may be hard for them to enjoy maybe social activities or keep their self-esteem high enough. I'll use fibromyalgia as an example for that one, because their quality of life dwindles because of their pain level. They cannot go out and be into society like they want to and function 100%. Hey, how are you?
Hi, nice to meet you.
Likewise, nice to meet you. Welcome.
Thank you.
Welcome.
So, and she keeps a lot of stuff back here too.
All right. Sorry about that. I love my office. So again, acute pain, medication, comfort measures. That is a good thing to take care of acute pain. Your chronic pain, these people are going to need multiple medication regimens or treatments, surgeries. But the problem with surgeries, they can also worsen the pain. Okay. Pain rating scale. We use the number scale, right? If we've got a patient with LOC ×4, right? We can use a number scale, but there's also other scales. On slide 17, you can look at the different types of scales. I think I have a page number. Hang on a second here. Page 133 has the different types of pain scales. Okay. Let's see if there's anything about that. Remember the definition of referred pain, right? The Wong-Baker FACES scale, this one can be used with pediatric patients, also in adult patients as well. Then you have the Flack scale. These are for your cognitively impaired patients. So if I got a patient with a Glasgow Coma scale of 9, I may use this one. You can use this for any cognitive impairment. They're unable to tell you what's going on with them. But research suggests, I don't know the history of the Flack scale, but it is useful in those patients when they have the impairment to respond to you. Okay. Let's see here. Racist pain. I gotta share this story with you guys real quick. I had a patient, right? First year of nursing, and this is important. It's gonna relate to you guys. I went into this patient's room. Now, medical history included IV drug abuse. Fine. I don't judge. Don't care. I will care for someone no matter what. No matter if they were an alcoholic, drug, it doesn't matter to me. Okay. This was an IV drug user. Very nice patient. Okay. Mid-40s, female. I won't say where I cared for this patient at, but frequent flyer that was there. Anyway, she was sitting in her bed, high Fowlers, on Facebook, because her laptop was up and you can clearly see it. She ate all of her lunch. She was watching TV, just flipping through the channels, no problem. Everything's like fine, or looks fine. And I have to ask about pain. And she tells me, yeah, my pain's an 8 out of 10. Who am I to judge? Okay, I'm not going to judge that patient. So what am I going to document? Well, I can only document what's objective in this case. The patient ate 100% of her food. That's an intake. I can document it. I'm still going to document that the patient said 8 out of 10, and then I have to do the entire pain assessment, because I'm not going to shorten it because I think that she's, not telling me the truth, that's not for me to judge. My license mandates me to assess for pain no matter what. So I did. That's what, guys, you have to do that. I need you to include that in your study plan because that is going to be important for you to understand. Okay. Even though your thoughts may be what they are, you must document what's objective. And the objective is the number scale, the 8 out of 10. What's objective is she did sit there and eat 100% of her lunch. I'm not going to include all the other fluff, patient flipping through the channels and watching Facebook on her laptop. I want to, but I don't have to. I don't need to. I just need to assess and medicate and keep vital signs in mind when I'm doing all of this and everything else that's going on with the patients. You take into mind the procedures they're going down to, if they have any. You take in mind what their medications for the rest of the day look like, what their intake has been, their trend. Okay, so you keep all that in mind when you're medicating and assessing your patient. Now, could you go to the doctor and say, hey, listen, during rounds, right? Let's say the doctor's doing walking rounds, coming around the unit, and that's what your patient's doing, 100%, watching Facebook, flipping through channels, reporting 8 out of 10 pain and wants IV Dilaudid. You can have a little conversation with the doctor and the patient included in the room. You don't need to hide nothing behind the patient's back. You go right in front of the patient and you say, entered the room, patient was on laptop, patient was also watching TV, patient consumed 100% of her lunch at this time, patient reports 8 out of 10 pain, medicated with whatever is ordered on the MAR. If it's Dilaudid, it's Dilaudid, but you let the physician know right during rounds. I guarantee you that that doctor will put them on a PO medicine or alter their pain regimen. Okay. But we need to prevent complications when we are medicating or caring for our patients or delivering any type of adjuncts to pain relief, whether it be pharmacological or non-pharmacological. Okay. Assess for any allergies. Okay. Then we need to evaluate. This is where the nursing process comes in. Go if it's IV, you want to go back in. So that's the most quickest onset, right? The most rapid onset is IV. It takes about 1 to 5 minutes to take effect for some medications, maybe 7 to 10. Your PO route is going to be 30 to 35 minutes. Okay, your sub-Q could be a little longer, right? Your IM also could be a little longer, depending on what medicine it is. If it's IM, did you do a Z-track? That's gonna, because that's going right into the muscle, trapping it into the muscle, right? So the absorption rate is going to be a lot slower, and for good reason, right? But you still need to go and evaluate their pain. You can go in an hour later. You can go in a half hour later. This is where you, the LPN, will decide to go in and assess, evaluate, excuse me, how the therapy was for them. Whatever route that you decided based on your order, if you did non-pharmacological, follow up. How did it go? Evaluate it and document it. Because if you didn't document, you didn't do it. Okay. All right, let's continue here. All right, let's continue through this pain. I'm not going to spend a lot of time in chapter 7 because you guys have been working with pain throughout the whole program. Literally, you've probably had migraines through the whole program. So anyway, if you're documenting pain, make sure you take a look at slide 26 on chapter 7. This is going to be an excellent example on how you can document pain and what you did and how you evaluated it. Right, I won't go into detail here. See if I got some pain page numbers. Page 135. This is important to include in your study plan because in figure 7.5, it shows you the areas that you could be experiencing pain and where it would commonly refer to, which is very good to know. Okay, very good to know. It's a nice colorful chart. It shows you, it also shows you there's some terms here. Also make note table 7.3 on page 134. It goes through common terms to help patients describe pain. But this reference chart is going to be key to know how you can help relieve this patient's pain and what's really going on. Somebody tells you, hey, and they're holding their center of their stomach right between their breasts, the epigastric region. And then they tell you, yeah, I've got pain radiating between my shoulder blades. That's definitely indicative of the stomach, right? If they got pain under the right rib, for example, does it radiate to the right upper shoulder? Important to know reference areas. Where is the pain going and does it make sense? Okay. I'm not going to go into much detail here. The page is kind of self-explanatory because it's a picture with colors. Okay. Let's see here. Page 137 as well. Please include this in your study plan. There's a blue box that says patient teaching. Remember I was telling you, medicate this patient before their pain gets crazy and out of control? Yeah, it says right here, take medicine before pain is severe and take it regularly until the pain is well controlled. Yeah, because it's harder to get to treat a 10 than it is to treat a 7 or a 5. Okay. On page, the same page 137, table 7.4. Read through this. You don't need to know all of it. You need to know about acute pain, addiction to pain relieving drugs, and what placebos are. You're going to see these again. Okay. Consider this a review of concepts. Now, what do we use to treat pain, right? Opioid narcotics. We use analgesics. We use NSAIDs. We use tricyclic antidepressants. Okay, are some medications, to name a few, and on how we manage pain. You have different therapies. If you see the term adjunct therapy, that's a therapy to help. That's a helper. Okay, that is when a patient is getting IV Dilaudid, for example, for post-op pain, and then all of a sudden they have an order for Tylenol or ketorolac, right? Toradol. Those are your adjuncts for your breakthrough pain. When they can't have pain medicine, you're not going to give a Dilaudid if it says Q 6 hours and they've got pain in 3, you can't give that Dilaudid again. This is where the adjunct therapy can come in and you can medicate per orders. Okay. Remember about fentanyl patches. Fentanyl patches are used for severe pain. The patch can stay on the skin for 72 hours. That's a method called transdermal pain relief. You need to assess if you have this patient with fentanyl patches, okay? Clinically, you need to go in and visually verify, remove their gown, look at their shoulders, check their back. Some patients, I had a patient one time, she had a fentanyl patch. You know what she did? I caught her sucking on the fentanyl patch like it was I don't know, a fruit or something, or a lollipop. Needless to say, we got that order DC'd and I took that away immediately. I can't make this up, okay? You have to assess your patients and how they're going to react. A PCA pump is another type of analgesic, right? They can press the button, patient-controlled analgesia, right? That becomes nice for the nurse and good for the patient because they can manage their pain safely that way. And you don't have to run in there Well, it's not that you don't have to run in there. They can manage their pain without fear of overdosing because it is a prescribed dose and it is programmed and it is double checked by a nurse and it's programmed not to exceed the maximum dose or minimum time ordered by the provider, which is really nice. It's an IV method. All right. You also have buccal swabs. They have buccal medications as well. I talked about transdermal. There's topical analgesics, right? Voltaren is one of them. That's a topical NSAID for your arthritis relief. Okay. Intramuscular, let's see, ketorolac could be IM. It's a liquid. It comes in a glass vial, and you would give this into a muscle. There's also epidural analgesics as well. I believe we talked about this in a lab. We didn't have an epidural pump. We did go over this. I showed you guys what part of the spine that would be in. Do you remember that? It was one of our labs. You guys with me or sleeping?
I'm here.
All
Yeah,
right, all right. All right, give me something. As long as you guys are still with me. Are you taking notes at least? This is important.
Yes.
That's the
Yes.
spirit. Good. Gonna need that. All right. Let's continue here. So non-analgesics used for pain control. I'm on page 140 right now, chapter 7. You can get methotrexate, okay, for intractable pain. This is normally your rheumatoid arthritis patients. You may get an antidepressant, okay. I've talked about tricyclic antidepressants, but antidepressants are first-line treatment for neuropathic pain. Immunosuppressants, that was one I just said, methotrexate for your rheumatoid arthritis. You could also get anticonvulsant medications, your Lyrica, your pregabapentin, and your gabapentin. Okay, these are approved pain methods for people who are suffering from fibromyalgia. They also have muscle relaxers, your baclofen. These are adjunct therapy to ease the pain in patients with back pain, like MS or muscular disorders or muscle spasms. Medical marijuana. Okay, this is another adjunct therapy. It's again, this goes by states and different types of providers. I'm not going to get into it. You're not tested on it, but it is a method of pain relief as far as the state of Florida goes. Okay. Yeah. Special considerations, meaning your aspirins, your anticoagulants, your Tylenols, because these have special considerations. These are telling you, hey, you nurse need to focus on this medicine, meaning if you got a patient that just had a surgery and they're normally at home and when they have a headache, they take an aspirin, we are not popping an aspirin post-operatively because they're going to put them at risk for hemorrhage, right? Or post-op bleeding, I should say. Also anticoagulants, right? Your heparins, your Lovenoxes. Let's see here. NSAIDs as well put you at risk if you have gastric ulcers or developing gastric ulcers that could bleed. Tylenol, don't go over 4 grams a day. This book says 4 grams. Other books say 3 or facilities say 3, but your med-surg book and HESI will say 4. So just know that because it relates to hepatotoxicity or liver toxicity. What's going to happen when you, so now we've got this patient, right? I was talking about my, what was it? Bowel resection patient, post-op, right? We're giving them IV Dilaudid, IV Dilaudid, IV Dilaudid. Well, what's going on with IV Dilaudid, right? Or IV morphine, opioids? Well, constipation. You know they're going to get constipated because it slows down gastric motility. Okay. When that happens, we need to increase fluid and fiber. Fluid and fiber. Some other side effects could be drowsiness, euphoria, right? Getting that amazing feeling like you're on top of the world. Itching, hives, most importantly, respiratory depression and addiction. Okay. You can give your patient, you may anticipate the patient being ordered Metamucil, right? Which is a fiber, okay? Fiber-based laxative. Miralax as well. That's another effective opioid-induced constipation reliever. You definitely want to educate your patients on those. If you're working in the long-term area, this is a recommendation you can give to your provider. Sorry, guys, throat's dry. And always follow your medication rights and your 3 checks. Very important. We are mandated to do that the right way. If we can increase our oral fluids while a patient's getting opioids, that would be ideal. If they can, if there's no contraindications. Okay. But what happens if a patient is overdosed on opioids? You may get a question about that. And you should be anticipating Narcan or naloxone. This is an effective opioid antagonist. You can give this IV or IM. Okay. It has an onset, I believe it takes 2 minutes, or you can give it every 2 minutes. I haven't given that one in a while, guys. I'd have to look it up again. But naloxone is the antagonist for opioids.
Every
Okay.
2 minutes.
Every 2 minutes? Okay, I remembered that one. Good. So every 2 minutes on there.
You know that
Say that again, Omar.
they have PO naloxone too.
They now have PO? I didn't know that. I knew they had the mist. I knew they had the IM and the IV. I didn't know about the PO.
Yeah,
Or I should,
yeah, I've run on scenes where I've seen patients with PO with pills and naloxone pills, and they were sitting right next to all the meds they take. They're like they were preparing to OD.
wow. So now is this a therapy that they give with patients going home with opioids? I'm wondering.
I'm not 100% sure, but I have seen it.
Okay.
I've seen it.
Be a good research topic, definitely, because of the amount of people. I had to do a project over the weekend. There is a new pain medicine coming out. It's like an opioid. It's like morphine, but it has no addictive properties. They took all the addiction properties out of it somehow, some way. Amazing. Let's see what else we got here.
Oh,
We can give opioids for end-of-life care, hospice care. These are your patients that they're going on that morphine drip for pain relief. Okay. Now, let's talk about options that you, the nurse, has for non-pharmacologic pain approaches. Heat, menthol, right? Like your mint. Menthol causes warming sensation and may have an analgesic effects. Cold helps reduce swelling and vasoconstriction. Okay. Distraction. Yeah, you can use distraction, relaxation. It helps relieve tension to certain muscle groups. Guided imagery. You help the patients create a mental image of a pleasant environment where they're comfortable. Tell them to picture what makes them calm, right? Meditation, you can teach them. The book also goes into hypnosis, biofeedback. This is where you use a machine that has electrodes attached to the skin. And the machine has colored lights and it has like pitches on it, pitches like sounds as it gets lower as the patient relaxes. Music is a good one. Okay. Post-op, you may see binders like abdominal binders. They look like a binder. Why is my mind drawing a blank? In Spanish, we call it a faja. but it's like it goes around the stomach and it kind of compresses the stomach area so you don't have pain, you don't have stretching when you stand up. Massage, therapeutic massage, that is. Acupuncture and acupressure. You may see a TENS unit or transcutaneous electric nerve stimulation and a spinal cord stimulator. Never use the spinal cord stimulator, guys, but it is in your book for us to use as a non-pharmacologic intervention. Some of these may require orders, like the stimulators, like the TENS therapy. You can find the TENS therapy in CVS now, which is pretty cool. You can tell your patients you recommend some of these non-pharmacologic ways, or this is something you can document as your plan of care for your patient, what you're going to do for their pain. Okay. These also include complementary and alternative therapies like yoga, chiropractic care, aromatherapy, and supplements. When I advise patients about supplements or any other complementary therapies, I always tell them to discuss it with their provider too for confirmation, but it is within our scope to advise them. Okay. Home care. We can discharge patients, teach them, and show them resources. We can teach them about adjunct therapy as well. Okay. I think that's all I had for you guys. Hold on, let me check my notes here. What are we going to do if a patient becomes drowsy and difficult to arouse, right? Regarding a child, unknown substance ingestion. What are you guys thinking? What could you recommend as the nurse? Maybe a child at home ingested an unknown substance. And let's assume it's a narcotic because the parent does have a prescription for it, but they left it on the counter. Okay. Now the child is difficult to arouse and drowsy. And they call you the nurse line because that's a job you can get. You can get a job for one of these insurance companies, maybe Cigna, okay, one of the major ones, and they have a nurse line. People can call you and ask for your recommendations. What are you gonna have them do?
Or poison control.
Poison control, okay. But he's drowsy and difficult to arouse. Poison control, yeah, that's a wonderful option. Omar, it is, but we really don't know the subject, and clinically, your pediatric patient is now going to deteriorate. What's another option you want to do?
Are you
Call
able to do
911.
Narcan?
Huh?
Are you able to do Narcan on them?
Unknown substance. If I knew it was an opioid, yeah.
Would you call 911?
911. Remember that, guys, because they're going to deteriorate fast. Kids will code faster. Good. You call 911. I need you guys to remember that. Okay. Because the parents of the child do not know the substance that's been ingested, the child is at risk to clinically decline faster, as they do. So you need to get EMS there immediately. Okay. That is going to be the indication, and that's something you can tell. If this is a phone call that you get one day working as a nurse line, or a family member calls you, or somebody calls you, call 911. There's nothing they're going to do to bring that child back in the house. They don't have ACLS meds sitting in there. There's no crash cart in the home. Get the ambulance there immediately. Okay. Let's see what we got here. Okay. All right. That's what I got for chapter 7, guys. I'm going to switch it now to chapter 44. Let me just pull up the PowerPoint. Any questions? All right.
No.
If you guys, I don't know I don't remember if I sent everybody the notice out, but I did send a video on YouTube about the cranial nerves. You can watch at your leisure. Okay. Okay. All right. Going to chapter 44. Anybody need a quick break?
Sure.
All right, take a 5 minute or 10 minute. I'll be right back.
Okay.
Okay, guys, back. All right, let's get into chapter 44. This chapter is pretty interesting. Do you guys remember that one lab that I totally threw you off that day? I had you come back into HVAC because we had some casualties, right? We had some victims from a disaster. Okay, that's what chapter 44 is going into, disaster nursing, and what it's about, and why it relates to you, the LPN. Okay, pretty important stuff. Because you could be the future of the task force here for emergency preparedness if you choose to get employed with them. You could be a resource. You are a community resource. Once you're done and out of here, you do become a community and a family resource. Okay. So in chapter 44, we're talking about the care of patients in disasters or bioterrorism attacks. Okay. Sounds far-fetched, but as we've seen with 9/11, it's not that far-fetched. These things do happen. And the way you are prepared is by having drills or a triage system, right? In the county that we live in, the Emergency Preparedness Center will do drills, and they work with the county health department to go into hospitals of their choice, and they do disaster drills with these hospitals. The nurses and doctors and the workers have no clue that they're going to do it, and they will surprise a hospital or an ER with disaster victims and see how well prepared they are. Okay, a disaster occurs when the number of casualties exceeds the resource capabilities of the area, right? So understanding your codes wherever you work at, whether it's a code blue, code pink, code green, code brown, sorry, you need to know that, okay? When I had you guys come back into HVAC and see those examples of patients and how the triage system can be used, okay? It's different from emergency room department triage, okay? Those with life-threatening conditions and a good chance of survival are cared for first. Okay, that's the difference. The mortally wounded and those who are not expected to survive are attended later. And these patients are often given a black tag. A black tag, meaning they're dead or they're gonna die and they have little chance of survival. They're going to the morgue, okay? I got the colors for that drill that or that lab that I showed you guys on page 1026 of your med-surg book, okay? In table 44.1, I utilized the disaster triage system for good reason. You've got some questions coming up on your next examination regarding disaster nursing and what you can do during it. Okay, so this table is important. You got your reg tags, your yellow, green, white, and black. Okay, and it tells you what color the tag is, what the classification is, the typical conditions, and their treatment, meaning how soon they're going to need to be seen or get treatment from a team of professionals, such as yourselves. Okay. Your nursing skills will be called to play under disaster conditions. Okay. Have you guys all experienced a hurricane before yet?
Yes.
Okay. If you are becoming a licensed provider, an LPN, RN, it doesn't matter. Nursing, it will change the way you think, the way that you interact every day. And one of them being because you are now a community asset. Okay. You are now the one that people call upon to get information because you've now studied it. You've had countless hours in clinical, didactic, lab, hands-on training The list goes on, okay? Some of the questions that you may encounter during, let's say, a hurricane, when there is a flood, okay? There is a table on 1033, box 44.1. It says keeping food safe to eat. Remember that if you experience a flood or somebody experiences a flood and they have canned food, and if the canned food comes in contact with flood waters, which the flood waters could bring sewage with it, you need to wash it with hot soapy water or make a bleach solution, meaning maybe 8 drops of bleach to 1 gallon of water, okay, and decontaminating the food. The box 44.1 on 1033 will go into detail on how you can care or prepare your patients or your community on how to properly care for their food while there is a natural disaster going on, such as hurricane. Okay. Fire safety is another thing, because carbon monoxide poisoning is a risk when there is a fire, right? What? How do you tell that a person is experiencing carbon monoxide poisoning? What's going on? A clinical sign of carbon monoxide poisoning is the cherry red color of the mucous membranes. It's like almost fiery red, okay? Carbon monoxide is a odorless and colorless gas. Yes. You say what?
No, hands, cheeks, that flushy red.
Yeah, yeah.
Right,
The,
right.
the hands, if they're face down, when you find them on carbon monoxide poisoning, whatever's facing up will rise and they'll become red there. But definitely hands, cheeks, face, palms, bright cherry red. But it definitely, their mucous membranes, fiery cherry red. Okay, definitely. All things important to consider when, please include in your study plan carbon monoxide poisoning from chapter 44. Let me see if I've got the page number. Hold on. Oh, botulism, 1039. There's a table 44.5. You want to include botulism. Okay. This is when you got canned foods that are dented. You want to avoid those because they could create botulism, and the definition is here. Okay. Let me see if they've got
Uncooked canned
hemorrhagic.
uncooked canned food.
Uncooked canned food. That's right. Botulism is a toxin. Definitely a toxin. There's 5 forms of botulism. There's foodborne, wound, intestinal, infant botulism. Okay. They're spores, and they occur when you have anything that's being canned or processed. Okay. It can be destroyed by chlorine. You can boil the foods for up to 10 minutes. Let's see what else I got here. Hold on.
What page are you reading from, Professor Carrera?
Oh, this one right here. Chapter 44.
Thank you.
Oh, look, it has the definition of a pandemic. I think we all understand that definition. Okay. You know what? It doesn't have carbon monoxide poisoning that I can find in here. Hold on. Why? I'll try to find it in the HESI book. I'll come back to that. It's got to be in here. Just please write down CO2 poisoning or carbon monoxide poisoning. Let's see. Psychological care. Anywho, what else was I saying? Hang on, guys. All right. We continue in the PowerPoints. So chapter 44, right? We're going to talk about signs and symptoms that go along with disasters and bioterrorism and agents along with it as well. It says that clinically we should participate in a disaster drill. You guys already did. I had that lab, remember? We all had no clue what we were doing in the HVAC room, but it related to this chapter. It was a little early, but it relates to it. So who's responsible for disaster drills? It's going to be Department of Homeland Security, FEMA, Federal Emergency Management Agency, and the U.S. Public Health Service. For us, it's St. Lucie County Disaster Preparedness Coalition. Yes, you can work there as a nurse, okay? Now, human-made disasters are anything chemical, biologic, nuclear, or weapons, your active shooter, okay? That can, that is a disaster right there. Your job as the nurse is to educate the community on disaster preparedness and what they can do, what we can do as a whole to be prepared. Honestly, we should think about our own lives first, meaning as a nurse, we should be at home and getting ourselves ready first, early on, okay? Page 1031, you are not going to be tested on what I'm going to tell you right now, but on page 1031, there's a green box that says disaster preparedness. I urge y'all to just read it. You're not tested on it, but again, you're about to be a nurse, working professional, you know, one of the highest functioning members of society, and you should have this information. All right. This is
Professor
important.
Ferreira,
It-
is there anything on organophosphate poisoning, anything like that?
No,
Okay.
not yet. Not actually not in this chapter, I should say. RN program, probably yes,
All right.
but not in here.
Okay.
Again, I urge you guys to read through this green box for your own knowledge. We should all be prepared first at home, and then we get the community prepared. Because if we're not prepared ourselves, we don't know what to do. Okay. When you go to Publix, when you shop in Publix from June to November, they used to hand you out a hurricane preparedness guide, and all it was this green box. That's what it was. Okay. So please, if you know, in your spare time, which you don't have, get prepared or think about getting prepared. Make a plan. You may be tested on HESI about evacuation plans, meaning if you've got a hurricane coming, you should automatically have a tornado, hurricane, or flood plan in mind, what you're going to do in the household, because that's how you're going to teach your community. That's how they will test you on HESI. So some of these things, there is a chapter in your HESI book about disaster preparedness. Again, minimally tested on, but it's still an option to be tested on. Now, let's keep going in the PowerPoint here. The American Red Cross are volunteers that check on residents when you get licensed. They're going to ask you if you want to volunteer for disasters. That's at your own choice. Meaning if you check the box when you get your license, they're going to call you when there's a disaster. Okay. Well, how do hospitals prepare for disasters, right? They don't know what's going to happen. They have these drills. The education department will get together with other nursing departments and they will come up with a disaster drill or formal training for disaster events, like active shooter training. That's one of the newest things that have been included as continuing education, right? Because now our society in this last 2 decades has increased tremendously active shooters. Okay. Chemical contamination. Every ER should have a decontamination area. The hospital that's in Vero Beach does have a decontamination area. Okay. You must decontaminate patients before bringing them into the facility. I know the one in tradition does have one. When we are decontaminating patients, we need to have an area specified, meaning this is like someone who got a chemical spilled all over them. Okay. And not just any chemical, chemicals that can penetrate your skin, gases that you're exposed to where it's all over you. They need to be completely stripped down quickly. Anything that has a chemical on it, pulled over the head, right? And should be cut a little wider so it doesn't get all over their face. Okay. Where am I getting this information from? It's on page 1037 in a blue box. Removal and disposal of contaminated clothing. That will be important because you may work in an ER as an LPN. And if you're, I know in Fort Pierce, the hospital that I was at, yeah, there were some gas leaks before at some of those industrial plants, and it was a code green, and people needed to be decontaminated. That's part of what they do. It's part of what you may do, depending on where you work at. Okay. Bioterrorism. It is the deliberate release of microorganisms, infective agents, okay, that are derived from living organism that causes death or serious disease in humans. All right. Let's see here. Our job during a disaster. We got to perform emergency nursing measures. The Good Samaritan law does protect us if we're out in the public and something happens. We need to evaluate the environment and physical risk shortages, like no power, okay? If there's a down power line and somebody, let's say you were driving, okay, you're driving. You know where I'm going, Omar. You know where I'm going. Let's say you're driving and somebody has a medical event and they hit an electric pole and now the power line is in the road and the car is hovering over the power line. The patient needs to stay in the car. Do not get out of the car. They will get shocked and they'll die. Okay. I've read some stories where people get out of their cars where there's a down power line and boom, zap and done. If they stay in the car, they can wait till that line is de-energized and then it's safe to get out. Because here we go back down to the chemistry of the body, protons, neutrons, and electrons, right? All that electrical conductivity, it doesn't match, right? We cannot get out of the car during that. These are some seminars that the nurse may want to hold one day and educate the population, right? Your garbage men. I tell you what, if I was a disaster nurse or if I was on the committee here in the county, I would have a meeting with those garbage men, women, garbage, doesn't matter. People, public servants need to know. And we got to put it in layman's terms. Hey, because why? They got those big trucks and they're at risk for maybe hitting a power pole or around it, right? Construction workers, what to do? Every time I drive by a roofer, I can't even look because I'm like, oh my God, if they fall, I have to stop. I have to stop and help. That's what we have to do, right? The Good Samaritan law will protect us. But anyway, please remember that. And we need to know the measures for prevention and control of health hazards. Food, water safety, guys, hygiene, all this comes into play. But food and water safety during a hurricane, Hurricane Francis and Jean, I sat through here. I cooked hot dogs on the motor of my car with aluminum foil. We had no power for like a week. That was horrible. So boil water was in effect. What does all that mean? Boil water. People can say, okay, boom, on boil water and turn it off. No, there's a certain chlorine solution. There's a certain time that the water has to boil, right? But you, the nurse, you're the resource for this. And I like to use it because we do go through natural disasters here. Hopefully none this season or the next. Okay, but the reality is at one point it's going to happen again. Okay, There is psychological stages, how survivors will respond. Just like with grief and dying, there are stages to disasters, okay? They are the impact stage, meaning stunned. They are stunned and disorganized for up to several hours. Then you have the heroic stage, where individuals want to be helped and ignore their own injuries for the benefit of the community, okay? Then you have the honeymoon stage, right? Kind of goes on its own description there, the honeymoon stage. This is where survivors are grateful. Hey, thank God I'm alive, blah, blah, blah. They have a sense of brotherhood and communal spirit. But then the disillusion stage comes in. This is where, oh my God, I really just lost my house and my pictures of my family that have been in the family for 5 generations now, right? You lost everything, money, cards, documents, gone. Okay, disillusion, physical and emotional fatigue ensues with this one. This is where people are at highest risk for substance abuse during this stage. And then you have the reconstruction stage. This is where people are coming together, and this stage could continue for years. People are rebuilding their lives. Rome was not built in a day, nor was our life, right? We cannot get back family pictures. Now, I'm talking about like, if you're like an 80s, 90s, 70s kid and we still had printed photos, now everything, you just pull it up on the cloud, boom, bang, done. Don't have to worry about it. Anywho, the stages, the psychological responses to disasters. Keep that in mind. Hey, just finishing the Zoom here with these guys. We have thermometers, limited supply in the cabinet right here. Oh. What? Well, yeah, right back. Give me 2 minutes, guys. Sorry, guys. A lot of illness going around right now. Something just happened. Anyway, let's get back here. Oh, we were talking about bioterrorism and chemical attacks, right? Now, how do we know that a chemical disaster is going on? It could be something as simple as seeing in a particular area, if you will, like the scene of a movie. Lots of dead animals like birds. If you live, an example, if you live off of Orange Avenue, right, back off the Groves, and you come out of the house and you're going down the dirt road to get to the paved road and on 95 and wherever you're working to, and you see a type of dead animal, and there's multiple types of them. Let's say all the birds are dead, maybe some reptiles or domestic animals even. Like all of a sudden the herd of cows, they're all down and dead. That's a problem. That could be something going on. A low-lying fog over that area of cows that are now dead. We need to be thinking chemical, right? Some kind of suspicious bioterrorism or chemical attack. This is unexplained. It's atypical for the region. You as a nurse should be highly suspect of what is really going on, because now if it's affecting mammals, well, do we need to be concerned? Yeah, that's a problem. Or even the type of insects, if they're all of a sudden dropping literally like flies, right? Got a problem. Hang on, let me get to this. Now, nuclear disaster, right? We do have the power plant in Hutchinson Island, right? One of the major power plants here. Well, how do we know if someone gets damaged from nuclear medicine? I mean, nuclear radiation, right? Acute radiation syndrome, they'll get GI, cardiovascular, and nervous system problems. And they'll also get bone marrow issues, okay? Again, it's acute. We cannot see what's going on with them internally, but they could present with some external symptoms. I do have a page number. Give me 1 second. So 1034 has your chemical disaster. Okay, now let me get to the nuclear. Page 1035. The key here is time, distance, and shielding are key to the quantity of radiation an individual will receive. That is a footnote that's right here on page 1036. Okay, again, person with nuclear disaster, they need to be decontaminated. That's another example. Some places will do an inflatable decontamination area for anybody that has gone through any biohazard, such as bioterrorism or nuclear radiation. Let's see, there we go. There's the table I was looking for. 44.4 acute radiation syndrome and what goes on with it, right? So minutes to hours, there's CBCs. You want to grab a CBC on them. They're probably going to be vomiting, okay? They're going to get chelation, like antiemetics, fluids, stuff to block those radiologic agents, okay? Again, here is going to be the table to go over. Not much on this one. I don't have much that you're going to be testing on it, just to be honest with you. Some concepts to note regarding disaster preparedness. Read the boxes that I told you about for your study plan. Include those. The only thing you won't be tested on is how to keep food safe, but it's a good thing for you to review, okay, for your own knowledge. Some biologic disasters, examples are anthrax, botulism, plagues, smallpox, viral hemorrhagic fevers. Okay. Smallpox is, there is an image in, if you're reviewing with me with your chapter 44, you'll see an image. You'll have lesions all over the body. I'm not going to go into a pandemic review, but we just lived through a pandemic. Okay. For you guys as the nurses on task during or after a disaster, you have to debrief. Mentally and physically, it's needed for you to debrief because of the psychological problems that we go through during these disasters. Okay. Debriefing is important, period. Whether if it's let's talk about a heart attack. Okay. I had a patient who had a heart attack after a surgery. He had an MI. Okay. How did I recognize that this patient had an MI? Well, they went into cardiogenic shock, right? They had an increased heart rate. He had a dysrhythmia and a decreased blood pressure. He was cool, pale skin, and altered mental status, and was reporting chest pain. Okay, we got him back. We got him back. That was a good story, but oftentimes they don't end like this. Okay, so again, for me, that's a disaster, period. We don't want to go through that as a nurse, but you're going to see these patients that come through to you. Remember what I just said about cardiogenic shock. Include that in your study plan and what it looks like. Okay, if you're reviewing, review cardiogenic shock. I guarantee you're going to see that come up again. Okay. But yeah, so anyway, after that patient suffered the MI, I had the patient for like, well, you know, in acute care, you don't get him that long, but I had him the day before and the guy was so nice. Not the day before, the day prior to that. It was another nurse that had him because I was off. But yeah, super nice. You create a bond with these patients. So debriefing was important because, you know, he went to ICU. It was a stable patient, you know, a young patient, you know, early 60s. To me, that's younger, healthy otherwise, but yeah, that's a risk post-operatively, right? It's just recognizing the cues. Same thing if you got a patient with SIRS, you know, systemic inflammatory response syndrome. Okay, how does that look clinically? Well, client presenting with 2 or more of the following, which is going to be temp greater than 102.2, a PCO2 less than 32, right? Because the normal range on a PaCO2 is 35 to 45. Okay, and they were tachypnic. They were like 24 respirations. That is a prime example. Or if their temperature was less than 96.8. Okay, remember that for SIRS. Okay. I can't say it enough, but debriefing becomes very important. Anyway, back to the slides. That's all the slides I have for chapter 44 regarding disaster nursing. You can read more if you like. If you're interested in disaster nursing, I've done some CEUs on it myself. Highly recommend. Very informative. Not for testing, but for your professional career in nursing. Let's see here. Let's put this aside here. Guys, give me a, I'm gonna stop this recording. Okay. This is going to complete chapter 7 and 44 for week 9 lecture PNR206. Okay. Come right back onto here. If you would like to join me, this will be the second part. And I'm going to go through your community class, a review of concepts from Dean Rivera that she provided me, which I believe you'll find very helpful for your next exam. Okay. Any questions on chapter 7 or 44? Okay, I'm gonna end this so I can save this recording. Give me at 4 o'clock, let's get back on here. 4 o'clock, meet me right back here if you would like to join for the community review. Okay,
I have a question, Professor Pereira. I don't have
Yes.
community. Do I come in? No.
no,
Okay.
enjoy the rest of your day then.
All right. Thank you.
You're welcome. Thanks, guys. But whoever wants to come back, please come back at 4. All right, ending the session now. Thanks, guys.